Track 19, Test 2, Exam Practice Listening. Part A. In this part of the test, you'll hear two different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a dietitian talking to a patient called Karina Bretby. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
So, Karina, you've been referred to me because you'd like to discuss your diet in relation to your ongoing treatment for pernicious anemia. I've got your notes here, but we haven't met before, so could you give me some background to your condition, please? When it started, any treatment you've had?
Sure. Well, with the benefit of hindsight, I can see it all began about 10 years ago. I had to have an emergency operation for a ruptured appendix. I mean, the blood problems didn't come to light then, but I now think that the symptoms could have been set off by that operation. Also, a couple of years later, so about 8 years ago, I had a biopsy because the doctors thought I might have throat cancer. I didn't in the end, but looking back, I can see that's when all this started.
You started to notice symptoms?
Yes, but very gradually. At first, it was just a general feeling of fatigue that I couldn't seem to throw off, but never bad enough to go to the doctor about. I just learnt to live with it. I also started to have trouble sleeping about then too. I'd be tired all day, then unable to sleep at night. I'd wake up with leg cramps. I'd have to get up and walk around to get rid of them. I was also needing to pass urine several times a night, and that affected my sleep too. It was about this time that I started to notice other things. I'd be cooking and I couldn't tell whether the food was salty enough. I was fine with sweet things, but I seemed to have lost some of my sense of taste. And I noticed I was getting clumsy too. I'd drop things and bump into things, and I'd never been like that before. Then, eventually, other things started. Like I'd get a really itchy nose. Or I'd get the same sort of feeling elsewhere, especially under my breasts. I mean, these things would come and go, and none of them was very serious. But looking back, I can see I should have seen the signs that something was wrong. In the end, my husband convinced me to go and see the doctor because I had a very sore tongue that simply wouldn't get better. It turned out to be a sort of ulcer.
So, was that when you got your diagnosis?
Well, not straight away. You see, the doctor immediately assumed I wasn't getting enough iron in my diet. That's because I'm a vegan, but I was sure that wasn't true. Anyway, when I related all the symptoms to him, he got more concerned and ran some tests to see if I'd got multiple sclerosis. That wasn't the case, fortunately, but the blood test showed that I did have pernicious anemia, so I started having treatment. I was put on daily B12 supplements to begin with, that gradually went down to weekly, then every 4 weeks, until eventually I was having them at 11-week intervals. To be honest, that was a bit too long. I'd start getting what people call brain fog after about 9 weeks. Then I'd be getting a bit short of breath by week 10. But generally speaking, I had it under control.
I see. So, what brings you to see me today?
Well, as you'll know, one aspect of the condition is that it makes it very difficult to conceive. We've been trying for some time, and happily, I'm now pregnant. It's very exciting. I've been taking folic acid for some time, and I'm now also on a daily vitamin D supplement. But I'm still a bit concerned. I've seen online that because of my pernicious anemia, there's a possibility of my baby getting spina bifida. So, given my diet, I just wanted to make sure I was getting the right sort of balance to reduce that risk. I mentioned this to my doctor, who referred me to you.
Sure. Well, thanks for all that background, Karina. That's really useful. What I'd like to do first is take a...
Extract 2, questions 13 to 24. You hear a doctor at a student health centre talking to a patient called Rory Aziz. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
So, Rory, I've got your notes here, and I see you've had treatment for anxiety. But as we haven't met before, I'd like to hear things from your perspective. Could you tell me how all this started, what treatment you've had, and anything else you feel I should be aware of?
Sure. Well, basically, I've always been a worrier by nature, I'm afraid. It's something that's always been there. Like, when I started school at 5 years old, I was vomiting virtually every day until I settled in, which took a couple of weeks apparently. And that was me as a kid. Everyone gets butterflies in the stomach before big events.
Yes.
But I'd be getting them every day because I'd be worried about some little thing. Then, in my teens, I'd just get anxious from time to time. I'd have these illogical fears that the absolute worst thing was going to happen in every situation, and I'd lay awake at night worrying about it.
Right.
And looking back, I can see that those anxieties were uncontrollable. There was nothing I could do to stop myself, and I never told anyone about them. Then, gradually, as I got older, I was getting them less and less. It seemed like I was growing out of it.
I see. Then you came to college.
That's right. It was fine at the beginning, but I was getting through a lot of coffee, and that might have been what sparked things off. One night, I had this sort of panic attack. I'd been sitting up late trying to finish an assignment, getting anxious about it. All of a sudden, I could feel my heart racing, and my whole body seemed to be tingling. Worst of all, I had the feeling that I was choking.
Right.
I mean, I'd never had anything like that before. It was terrifying, and it really shook me up. The next day, I just felt kind of lightheaded, and I'd get these spells of dizziness. They just sort of came on out of the blue, and I was back to imagining the worst again. I went online and tried to find out what was wrong with me, because I had other symptoms too, like my mouth was really dry, and I was sweating profusely for no apparent reason.
Right. And is that when you came here to the health centre?
Yes. I told the doctor what had happened. She did a few tests, to see if I had anemia or perhaps an overactive thyroid, but I didn't.
Right.
That's when she diagnosed me with GAD, generalised anxiety disorder. It was actually quite a relief to put a name to it, to think there might be a cure, and we talked about different treatment options. In the end, I went for CBT. I did 4 months, and the therapist was great, but I am still getting the physical symptoms. Not as bad, admittedly, but I'm not cured. I know it takes time, but I'd like to try something else.
Okay. So is that what you wanted to discuss today?
Well, a couple of things, actually. Firstly, I wondered if I could try what they call applied relaxation. Apparently, it's another type of therapy like CBT, and I read that it can really work. I'd just like to feel that I've tried everything before going on to medication, because I know that's the other option. I was reading about antidepressants. I know that's one of the things on offer, but there seem to be quite a few side effects. Perhaps you could talk me through what's available and what the pros and cons are?
I'd be happy to.
Oh, and the other thing is that I've noticed something that's really worrying me. I can feel a lump.
Right.
I don't know if it's always been there or whether it's just appeared, but it's on the back of my head. I can't stop thinking about what it might be.
OK. But before we go any further, perhaps we'd better take a look at that,
That is the end of Part A. Track 24. Test 2 Exam Practice Listening. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear 2 hospital nurses handing over a patient at the change of shift. Now read the question.
So in bed 8 we have Mr. Ferris, who has chronic COPD and was admitted via the emergency department with suspected pneumonia.
OK.
He's been feeling slightly better on my shift. His temperature is 37.3, pulse is 69, respiratory rate of 16, blood pressure 129/80. His chest x-ray of last week showed a stable left lower lobe infiltrate, but only normal throat flora showed up on his culture. Having said that, his urine antigen was positive for strep pneumonia. So the doctor's assessment is that the pneumonia is steadily improving. The plan is to discontinue his IV ceftriaxone as of this morning and continue his oral azithromycin.
Right.
If he continues to improve, it looks like he might be ready to go home tomorrow. He's alert and oriented, so we could share that information with him this afternoon when his wife comes in, just to see if there are any issues their end.
Sure.
Question 26. You hear a senior care home nurse briefing her team about patient mobility. Now read the question.
Today, I'd like to show you a video about patient mobility. Now, experience tells us that our patients may have difficulty getting out of bed and often need to be encouraged to sit in a chair instead. We can remind them of the medical reasons, that it can help prevent chest infections, normalise blood pressure and increase stamina. And of course, we know it makes them more likely to socialise and participate in their surroundings. So the clip I've selected goes through the steps in guiding a patient transfer from bed to chair. The assumption being that the patient has minimal or low handling risk, but needs assistance from a member of staff. Now remember, to perform this manoeuvre, patients should be clinically stable, be able to bear their own weight, and initiate their own movements. And they must be capable of understanding and following instructions. Let's watch.
Question 27. You hear a community nurse talking to a patient. Now read the question.
So, that's the injection all done. Is there anything else I can help with?
Well, there is actually. I think I may have broken my finger. It's really weird because sometimes it's almost as if I've lost control of it, especially first thing in the morning. It's all bent double and it takes time to get moving properly. Even then, it doesn't move as quickly as the others. It kind of lags behind. Then other times, like now, it's back to normal. The thing is, I'm at a keyboard all day because that's how I make my living, so I really can't afford to have it in plaster or strapped up. The really weird thing is, it doesn't hurt at all. You'd think it would if I'd broken it, wouldn't you? Do you think I should see the doctor?
Maybe. Can you show me which finger it is?
Question 28. You hear a primary care doctor talking to a practice nurse about a patient. Now read the question.
Could I have a word with you, Molly?
Yes, sure.
You're going to be seeing Mrs. Walsh. She's an 82-year-old lady who's coming in to have a dressing change following minor surgery on her varicose veins.
Oh, yes. I know Mrs. Walsh.
Great. Well, when I saw her, I was a bit concerned that she seemed to be a bit disoriented and confused. She picked up a UTI when she was in hospital and so ended up staying longer than planned. She's mobile, so she'll be coming into the clinic. Otherwise, it would be something the community nurse could follow up. Could you just keep an eye on her, get her talking, and see if there's any cause for concern? If there is, we'll have to think about setting up something more formal.
Sure. I'll report back to you either way.
Yes, please.
Question 29. You hear a community pharmacist talking to a patient. Now read the question.
How can I help you?
I just wanted to ask you something. You see, I've been given some pills for my heart condition. It was the consultant who prescribed them, and she said they were low-dose beta blockers, and that I should take them as and when, only if my heart started playing up, and then only until it got back to normal, then to stop. Anyway, my daughter picked the pills up, and I only noticed when I looked at the box that it says, "Take 1 tablet daily." So I went online, and sure enough it says they're beta blockers, but all the websites say that's how you should take them, not as and when. I mean, I just thought I'd make sure I've not got things mixed up in my own mind somehow.
OK, I can check that for you. Have you got the pills with you?
Question 30. You hear part of a safety briefing on a hospital ward on the subject of hand hygiene. Now read the question.
So, on to the question of hand hygiene. Now, in the questionnaire I sent round, many of you said you'd like to improve your hand hygiene compliance. Hand hygiene's always been important within healthcare, and the global COVID pandemic really brought this home to us. As you know, we replaced the rather uninspiring training videos on this subject with the Clean Hands interactive training package last year, and that's been getting lots of positive feedback, although take-up could be better, to be honest. With that in mind, you'll be pleased to hear that the package is now available on desktop and other platforms. This makes finding the time to engage with it so much easier, so there's no excuse for putting it off any longer. Infection control has never been so critical.
That is the end of Part B. Track 28. Test 2 Exam Practice. Listening. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a nurse called Maya Layden giving a presentation on the subject of hospital visiting times. You now have 90 seconds to read questions 31 to 36.
Today, I'm talking about a bit of a contentious issue: hospital visiting times. Many healthcare facilities allow visitors at any time, whereas others, in particular large general hospitals, have policies that restrict both visiting times and visitor numbers. There are arguments on both sides. Historically, hospital visiting was controlled for a variety of reasons. Generally, the policy stemmed from a belief that patients only needed to interact with clinical staff, and that this interaction was, in itself, therapeutic, a notion that's now widely regarded as unfounded. Another reason was the need to protect patients, and of course also visitors, from the risks associated with epidemic diseases and infections. And this is still relevant today. Studies have shown that external visitors account for almost 25% of all visits to the bedside, and they are a potential source of infection. Restricting visiting was also a way of ensuring that a ward ran smoothly and that patient dignity and confidentiality could be assured. You'll still hear this argument being put forward, and as there are these potential difficulties with unrestricted visiting, many hospitals continue with the tradition and restrict visiting. Indeed, the well-intentioned and widely adopted practice of protected meal and rest times, once a mainstay of hospital policy, still has its advocates. A recent systematic review, however, found it made little difference to either patients' overall experience of hospital or their health outcomes. Studies of ward quiet times, which presuppose visiting restrictions, have shown them to be good for some patients, but not for all. And of course, in a hospital setting where there are open wards with bays rather than single rooms, open visiting might mean all patients being disturbed by noisy visitors or by any arriving at unsocial hours when the majority are resting. But some would argue that policies supporting open visiting recognise the importance of relationships for patient recovery and are therefore, arguably, more patient-centred. So, what about the staff perspective? An argument you'll sometimes hear is that having visitors at the bedside may mean staff feel they can't disturb the patient, and therefore can't attend to tasks such as washing or changing dressings. This may cause anxiety amongst staff, as it interferes with set routines and protocols, and so may even threaten patient safety. This is an issue. But maybe it's those routines that need to be revised and adapted to accommodate the more compelling notion that friends and family play a huge role in patients' emotional well-being and are therefore vital to their recovery. There's evidence that open visiting benefits patients when family members are involved in their care. For example, one study found that their presence during ward rounds offered new information in almost half of cases, whilst also acting as a second pair of eyes in terms of the consistency and accuracy of care. Family involvement in care has long been the norm in paediatrics, where open visiting for parents is the norm, and it's increasingly encouraged in other settings. The argument goes that as most healthcare is actually delivered in the home by informal carers, why still have rules that preclude this during a hospital stay? It seems weird that times when visitors can be most useful, like early mornings and meal times, are the very times when visits are restricted. To some people, the idea of open visiting sounds like something of a free-for-all, with families and friends coming and going at all hours, disturbing patients. This may well happen, and I can see why people might be worried, but any impact's likely to be limited to a few cases. Visitors have lives too, and most will need to go home to eat and sleep. The majority of visitors are, in fact, sensible about their own needs as well as those of the person they're visiting and other patients. Some studies suggested that open visiting needs to be tempered with caveats, allowing patients to rest as and when they need. This means there's a role for nursing staff to play in advocating for patients who need their visitors to sit quietly or even to leave. So, what conclusions can we come to? Health professionals who advocate restrictions often say their actions are in the patient's best interests. But how can these be ascertained, and what interpretation of that notion should be applied? Hospitals are, by their very nature, social institutions, where the needs of the many may necessarily take precedence over the needs of the few. It may seem reasonable to restrict visiting so that everyone benefits from peace and quiet, but that's a subjective view that's not backed up by empirical evidence, so the outcome of such a policy is unproven. Restricted visiting feels like a relic of a bygone era and an anathema to the principles of person-centred care. Where still in place, it needs to be reconsidered.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear an interview with a tissue viability nurse called Matteo Moran, who is talking about the use of maggot therapy in debridement. You now have 90 seconds to read questions 37 to 42.
My guest today is Matteo Moran, who is a tissue viability nurse, and we're talking about debridement techniques, and specifically the use of maggot therapy, where the larvae of insects are used to debride wounds. But this isn't a new technique, is it, Matteo?
No, it's not new. People have probably known that maggots can help wounds to heal for centuries, but it's only during the First World War that this gets documented. It seems incredible to us today, but Dr. William Beyer actually observed the positive effects and outcomes of unintentional maggot infestation on open battlefield wounds. Later, he went on to initiate the use of sterile maggots as a reputable method of wound therapy, and this flourished, especially in North America, for many years. By the mid-20th century, however, the clinical use of penicillin had ushered in a new era, and predictably, the use of maggots for debridement was an early casualty of that.
So, what are the advantages of maggot therapy over other forms of debridement?
For years, anecdotal reports from wound clinicians have suggested that wounds treated with maggots had better outcomes compared with those treated by traditional sharps debridement, and that the risk of amputations was reduced. It's only recently, however, that these healing effects have been scientifically and clinically investigated. There's now growing evidence supporting maggot-induced acceleration of healing, and, crucially, from my point of view, that this can actually result in an overall reduction in the reliance on antibiotics that's a feature of sharps debridement. Studies also suggest that, in all respects, this is a comparatively cost-effective wound treatment.
So, why isn't it being adopted more widely?
Well, even though the efficacy of larval therapy is well established, its adoption is limited by several issues, including practical problems associated with the use of living organisms. For example, there's only currently one company specialising in the sterile production of medicinal maggots in the UK, and these have a short shelf life. So quantities are limited, and you need access to a logistics network for express delivery. This is a barrier to wider use in the short term, and even when that's overcome, there'll still be a need for training to ensure that maggot dressings are applied and maintained correctly. Basically, maggot therapy should be used cautiously and under close supervision near exposed blood vessels and cavities, as there's always some risk of adverse effects, such as bleeding and pain.
And how do patients react to the idea?
Anecdotal reports suggest the potential benefits of maggot therapy are overshadowed by the yuck factor. In other words, an inherently negative cultural dislike of maggots. Surprisingly, however, although some of my patients may express anxiety when the therapy is first suggested to them and first applied, most are very keen to go through with it. This is because of the profile of the typical patient. We're talking about people who've often suffered with a non-healing stagnant wound for long periods, so they're quite desperate for some improvement. Indeed, for patients with a chronic wound, the offer of maggot therapy is often their final hope. One study found that the main concern of patients and their carers involved the social stigma of undergoing the treatment because of entrenched attitudes in the community at large, but that's not been my experience.
And what about healthcare staff?
Well, anxiety about the use of maggots is certainly not unknown amongst healthcare staff. One study has actually suggested that health professionals and administrators are more likely to be repulsed by the thought of maggot dressings than the patient with the chronic wound. But in the UK, wound care is predominantly nurse-led, and wound specialist nurses rated maggot therapy highly in the study's findings. But non-specialist nurses were generally more squeamish and more affected by feelings of revulsion. This highlights the need for better education and training for all nurses. If general ward nurses refuse to help and support the ongoing therapy, that's something that could potentially inhibit the ability of specialist nurses to offer this treatment to patients who might benefit from it. But that's not seen as a likely scenario.
So, what about the future of the therapy?
During the last decade, Thousands of patients worldwide have had their wounds successfully treated with maggot therapy. It's recognised by many clinicians as an important treatment in its own right, and by others as an adjunct to conventional wound care therapies. Wound care professionals are constantly searching for a dressing or medical device that will selectively debride necrotic tissue whilst decreasing the bacterial burden of a wound, preventing or removing bacterial biofilm and promoting the growth of healthy new tissue. The mounting evidence from scientific, published investigations, randomized controlled trials, successful clinical studies and case studies indicates that maggot therapy may come very close to addressing all of these factors.
That is the end of Part C.